Hi guys, we're back with sessions 40, and this one is going to be part one of maybe 3 or 4 sessions. We're going to talk about clinical situations in review. There are many topics, clinical topics, that you can find at dearnurses.com. Some of them you may be aware, some of them you may not be aware. So I was just going to pick out some of them that might be of interest to help you in the clinical setting. Let's start with cardiogenic shock. The patient in cardiogenic shock. Here is a patient, 46-year-old female, admitted to the hospital with a diagnosis of chest pain. 2 years ago, she had a myocardial infarction and has been coping fairly well. This morning, she woke up with shortness of breath and is very anxious as she uses her call light to call for help. Well, here we can see she's calling, "Nurse, I need help. I feel like I cannot breathe." What if you were the nurse put in that situation? Would you really know what to do? So if you would just go to dearnurses.com and look at cardiogenic shock, a case study, there is just an overview of what you might be able to do in that situation. Now be aware you always follow your institution's policies and procedures and doctor's orders. And so we're going to move to the next topic, which is chest pain. Hardly any nurse can say she has not had that situation, the patient having chest pain for one reason or another. Now, when a patient has chest pain, it might be related to stress, it might be related to some other underlying pathology. What is clear is it needs to be addressed. Chest pain should always be assessed and letting the doctor know, and then he will decide what action, what course of action, whether he's going to follow it up with tests of different kinds. Chest pain may feel like an extra pair of hands squeezing the chest. It may feel like a stabbing pain, like a knife stabbing into the chest. It may even feel like pressure in the chest, radiation to the shoulder and neck. One thing is clear, it should be assessed. If a patient is having chest pain, you should take the trouble to assess the pain, document your findings, notify the doctor, and follow his instructions. Again, go to dearnurses.com, master your clinical skills, and that would be of help to you. Now we're going to talk about the cranial nerves. I'm sure some people have heard of them and some people vaguely know of them. We know that the cranial nerves, we have 12 pairs in the brain. They're just not some nerves sticking out of the head. They actually serve a very useful purpose. Take the case of the stroke patient. The glossopharyngeal, which is the 9th cranial nerve, and the vagal, the 10th, may very readily be affected in the stroke patient. This would impair swallowing and gagging, which is what gives you the ability, if something goes down the wrong way, to cough it up. If you take the time to go to Stroke Assessment in the Clinical Setting, Volume 2, it gives you an overview of the cranial nerves and how they're used. And next we're going to talk about the patient with a subarachnoid hemorrhage. A subarachnoid hemorrhage may start with what is called an explosive headache. Patients who have this condition will describe it as having a headache like they've never had before. What is clear is that if you should have a patient complain of an explosive headache, it should not be ignored. You should take the trouble to assess and document findings and notify the doctor again. Let him decide what he wants to do about it. And you may never have been exposed to what is called intracranial pressure monitoring, but if you take the time to go to that case study at dearnurses.com, subarachnoid hemorrhage, you should be able to familiarize yourself with some of the situations, the indications, and what goes on. And last but not least, we're going to talk about the patient with meningitis. I apologize. Meningitis is also discussed in that scenario too on dearnurses.com.